Okay, so welcome everybody to this morning's Making Digital Health Real. Before we start, I'd just like to acknowledge the traditional owners on the land upon which I'm coming to you from today, which are the Wurundjeri people of the Kulin Nation. And I'd like to pay respects to elders past, present and emerging. We're incredibly excited to have Grahame Grieve with us today. Just a little bit of a history or a story about Grahame is that he started out as a clinical chemist and has since stayed working in healthcare, and I think we're incredibly fortunate for that. Grahame has held a variety of roles, from PhD researcher looking into biochemical impacts of diabetes in cholesterol metabolism, and more recently consultant to national programs on adoption and implementation of interoperability standards, including the Australian National Health Record System. So Grahame is currently HL7's Product Director for FHIR. And for those not familiar with what FHIR stands for, that's Fast Healthcare Interoperability Resources. And it's a leading healthcare data exchange standard globally. Or maybe I'm out of place saying that. In that role, Grahame is responsible for the growth and governance of the community that develops the FHIR Specification, managing the corporate and government relationships around it, which are crucial, and acting as a lead editor for the specification. On that note, I don't think that's really done you justice, Grahame. And this is what this talk is about, is for you to give us some insight in your pathway into digital health, and more specifically, FHIR. Thank you.
Okay, sure, thanks. I mean, hopefully I'm going to talk more about digital health than about me. That's the point, really. So let's see, let's get the slides going. All right, so slides. I bet it goes the wrong way. No, I've got it right this time. Okay, so you should see my slides, yes. All right.
We can see them.
Okay, so hopefully we have plenty of time for questions. That's my instructions, so I'll try and do that. We live in a really interesting time. You probably can't see the actual bit that matters, where we're standing on the cliff looking down at a huge potential, but we can totally fall off the cliff right now and completely stuff it up with digital health, or we can actually make people's lives and health better. But which will it be? And it's our chance, our opportunity to change the game. It will change somehow. So FHIR. So really the genesis of FHIR was back in 2011. I sort of came to a bit of a crisis with my involvement at HL7. I had been involved at HL7 for 15 years, one way or another. I had worked myself into some leadership roles at HL7, but I had to accept that HL7 had lost its way. And there was plenty of evidence for that. And it was really hard. It's a whole organizational social change thing, because if an organization you're completely committed to has lost its way, the very first thing the organization does doubles down and does everything that's doing harder. And if it's doing the wrong thing, that makes things worse. And you can see plenty of that. You can see that today with a certain Elon Musk running Twitter. Very amusing, in fact. Everything doing the wrong thing and doubling down and doing it harder. But let's stick with digital health. So healthcare has broken processes. Most of us have lived those processes. We know that everybody, and I'm sure plenty of people on this call, are part of the provision of processes in healthcare, and you do your very best to make sure that the bit you're responsible for is world-class. We all do. It's the gaps between all the world-class bits that are very far from world-class. Although actually, having looked around the world, I really can't say that. All the world has the same problem. People's health, the problem is the transitions. We know that. But the processes are broken. And other industries were being transformed. I was watching the transformation back in 2011, and IT enables process transformation. IT is not the process transformation. And that's a common theme wound through all of this, is that digital health is not the solution. Digital health is a tool that can be part of a solution in healthcare. There's plenty of misinformation and misapprehension about the role of digital health there. But what was clear back in 2011 is the process was not happening in healthcare. And part of that was because the standards to integrate business to business and consumer to business, and I use business to talk about healthcare, not making money there, don't exist, do not exist, did not exist then. And the IT that did exist was not properly implemented for a variety of reasons. As I said, there's a lot of other problems, but for me, what was the point of taking on those other problems if the IT space wasn't able to support better ideas? And so I said, I'm going to take on the IT space. I'm in a good place to do that positionally, and I'm going to extend myself and have a go and see how we go. So that's really the thinking behind FHIR. So if you look at what led to those changes, the key for me is Metcalfe's law. I don't know how many of you are familiar with Metcalfe's law, but the idea of Metcalfe's law is a decentralized social web has a characteristic that the value of your involvement scales up faster than the cost of your involvement. It's a non-linear arrangement. You have value from having a phone that you can use to call anybody. You didn't spend money to get them to get phones. And so initially there was no point having a phone, and then suddenly everybody had a phone, and that's Metcalfe's law at work. So how does that apply to healthcare? That's what was happening in other industries. And it's backed by mobile, so you can get to everywhere people are, analytics so that you can learn and iterate and become efficient, along with cloud, so you're not localized. Those things were driving other things, and we'd seen major changes. 10 years more experience under our belt, we've also seen that those things that are pretty awesome have pretty awesome challenges. And for me, one of the big learnings that I had already seen back then was the necessity for open protocols. Because if the protocol is closed, the ecosystem is closed, and the benefits are closed. And so I decided to focus on the ecosystem and the protocol. Before I go on, is digital health actually good for health? Is digital good for health? And we all know that there's plenty of skepticism about this, rightfully so, because there's lots and lots of people running around with solutions looking for problems, with hammers looking for nails, sledgehammers looking for walnut peanuts. Have we made it better? And it's kind of one of those things where everybody says every single change has made my life worse, but we would never go back. And so I still think that it's for us to actually make a good case that digital is good for health and to do it well, but we have to do it well. I've got here on the slide a bunch of ways that we could make health better with digital processes, but they're all easy to do badly. And also they threaten someone's existing business model. It's my contention that the existing business model for GPs is doomed because of AI in the medium term. But like, how do we deal with that? How do we do it well as opposed to doing it badly? Many big questions. And I didn't want to like say there's some sort of automatic nirvana where if you do your digital right, it's sweet. It's not. But I set out with FHIR to say, let's take IT out of the problem. Let's make IT not the problem. And so my stated goal was that we would reduce the cost of interoperability, the cost of exchanging data by 90%, an order of magnitude reduction in the cost. People laughed at me. Can't possibly do that. But I said that if you can do that, then you can get more outcomes for the same investment. Because people aren't going to spend less because they're getting more. They're going to spend more because they're actually getting benefit. Because sometimes it's pretty hard to show the benefit. And 10 years later, we're at the point where the transformation is already evident. that I'm talking about here, but we're far from complete. We will increase investment. Now, of course, as I said, and I'll keep saying, this is not about IT, it's about health. Data is worthless. IT is just an enabler. Healthcare process and culture is what matters. But I will say at this point that we exceeded the order of magnitude reduction of cost of interoperability we wanted. So here's an example, which is the best example. That's why I've given it to you, of course. Back when I first started working on FHIR, the theme of the year at HIMSS in USA that year was personal health records, connecting people's individual personal health record to give them personal access to their data to an institution, a hospital. And there were PHR companies running around HIMSS trying to convince institutions to invest in that. I sat down with a couple of integration experts who were supporting the process, and we summed up the cost, the total cost of ownership, sales, contracting, development, testing, lifecycle maintenance. The total cost of ownership was easily in excess of 120,000 US for that process. This year, if you're a hospital and you want to make data available to patients, you register yourself with Apple or with one of the other providers. They run their tests on you, and then you turn it on. There's no cost. There is no cost. How about that for order of magnitude reduction in cost? That's the kind of thing you can achieve by an open protocol-based ecosystem. So yes, we did reduce the cost of interoperability. So we did through HL7. I'm not going to tell you any more about HL7. This is for the people who just want to see the slides later. So FHIR, Fast Health Interoperable Resources. The first thing to tell you is what the letters stand for is completely irrelevant. We just wanted something that had a joke associated with it, the flame, and that was globally unique. And the marketing committee came up with that, and that's what we went with. But FHIR actually stands for Fixing HL7's International Reputation. So there. So it's two things. It's a community that meets under the umbrella of HL7. And for me, as the community manager, the community is actually the important bit. It's the bit that matters. It's the bit that actually has made the difference. The community meets through HL7. We are dedicated to making it easier to exchange healthcare information using the web. And web infrastructure, we mean socially, we mean culturally, we mean technically. And we argue about things. That's what we do. We argue, and then we publish a specification, which is the outcomes of our arguments. We make it freely available on the web. It describes how to exchange information about healthcare processes. And basically, we add the healthcare knowledge to web standard infrastructure. So it's open, freely available. So it's the web for healthcare, community and standard. And one of the key characteristics that we bring is continuity with existing healthcare standards. It would be a lot easier if we just started from fresh. We started and said, let's wipe the entire healthcare system off the table and build one from scratch. I mean, how many people I'm sure most of us listening have had that fantasy to ourselves occasionally. We couldn't possibly do worse than what we have if we started from scratch. Of course, with enough knowledge, you realize we totally could. We could do much worse. And individually, we probably would. But doesn't mean we can't find areas for improvement. But the continuity of the existing healthcare system is a big constraint. And then we said this open community, anybody can join. There's no membership cost. There's no nothing. You can just be part of the community. We produce open standards. And they have this really weird property. The thing about open standards is everybody owns them. Because everybody owns them, everybody is richer. So I call that community treasure. And it's like, if actually any individual organization, a company owned it, it would be worthless to everybody else because they'd have to pay for it. So proper, well-governed, open community produces community treasure that makes everybody richer. But to do that, we have to have solid governance. In this case, we're backed by the American National Standards Institute, which says and checks rigorously that we say what we mean what we say, we do what we said, and we keep good records of that. And then we build by iteration and continuous demonstration that we reward that trust that people have in us by delivering on the process and being open and consistent. And then that means that big companies, billion-dollar companies, come to us and give us their best people, their best tech, because they know that they're better off if everybody owns it, and they trust us to own it on behalf of everybody. And so it's that combination that is actually what we manage and build. And then the output, the technical standards, the whole stream of them, that's, just the record of what we agreed. So you too can join the FHIR community. There's with the FHIR Spec where we hang out. Hey, I originally wrote this slide for a Russian presentation. I'm really going to take that line out since, well, Russia was a problem. All right. So here's a bit of a scan of where FHIR is being used around the world. The units are totally meaningless, but you can see that we've got pretty good adoption scattered across the world. Obviously a huge focus on Amazon data centers, no surprise. This is actually the hit counts and the test servers. There's all sorts of integration processes and so forth, but you can see we've got good coverage. Next week, I'm off to South America to see if I can build the South American coverage. What we'd really like to do is see much more coverage in Africa. So that's something I'm working on next year. A little change of pace. To understand data exchange and interoperability, which is the capacity for data exchange, is to understand, for me, 3 principles. The first is that interoperability is all about the people. It's not a technical problem. You hear this all the time, oh, it's a technical thing. But really, it's actually not. It's about getting people to agree with each other. So pretty much a lot of what I do is actually diplomacy rather than, technical problem solving, because everybody knows how to solve the problem, but they all solve it differently. And the point of us is to get us to agree. So it's a people problem. And the corollary of that is that people who aren't good at interoperating with people aren't going to help solve the problem. And we all know not everybody is very good at interoperating with other people. So that's, for me, a key. In fact, I worked on a project for a while where 2 separate companies were working on on 2 ends of the same, of a data exchange. Initially, because they didn't have time to write a specification and agree to it, they just started both writing the implementation. And then they send their engineers along to a weekly meeting to reconcile their implementations. The engineers quickly got hostile and the meetings turned very difficult. And because they couldn't agree, because they weren't empowered to agree. And so the organizations looked at that and said, well, that's not working. So they pulled out the engineers and sent along marketing people. The marketing people got on with each other awesomely. It was great. Everything was perfect until they turned it on, in which case nothing worked, because the marketing people got on with each other by sweeping issues under the carpet. Interoperability requires you to find the middle ground, people-focused but detail-orientated challenge. Very hard to find those people motivated to do that. And in fact, looking around the world, yes, culture's a problem. Yes, business motivation and business arrangements and government funding models are a problem. But the real problem we all have is finding the right people who are motivated to do the work. And I wish that we were much better at making the value proposition for digital health as an infrastructure, as a fundamentals to students, to doctors, to programmers. 90% of the programmers in health just are drifting through health. It's just another industry. So the second law is that complexity exists. You can move it around or make it someone else's problem, but it doesn't ever go away. Of course, you can make it worse. We're all good at making it worse. And so the essence of a good solution is not to make it worse, but also to make sure it gets solved. I've certainly met plenty of project teams who've looked at the complexity, figured out how to make it someone else's problem, and then declared victory. But actually, they haven't solved anything because they can't work with anybody. They can't solve their problem because they just took the complexity and made it someone else's problem. And of course, when it comes to paying for things, it's a favorite thing for everybody to make someone else pay for complexity. But it doesn't solve the problem. And a lot of digital health things fail, in my experience, because everybody's trying to make someone else pay for the complexity. But of course, you're not explaining that to them, because what would be the point then? So that's a key law of interoperability. And finally, flexible, interoperable, and cheap. You can't have all three. They trade off against each other, and a flexible, interoperable system is going to be expensive. There's just no two ways about it. Of course, a lot of people look at this rule and go, you can't have any two of them. I'm not sure you can have one of them. And of course, those things are challenges. But my point is, you can't have all of them. They trade off against each other. You can have interoperable and cheap, but it won't be flexible. Or you can have, flexible and cheap, but it just won't be interoperable. You just can't have all three of those things. So I coined them many years ago, and you'll run into them occasionally. But for me, they're key understandings about what is happening when you're trying to do interoperability. On the subject of interoperability, the IEEE definition, which everybody quotes as the classic definition of interoperability, is the ability of two or more systems or components to exchange information and to use the information that's been exchanged. But to use them, how? Who cares? I can take it and I can use it by putting it in the bin. That was using it. Doesn't help anybody. So I've been trying to plug around the world that a definition like the ability of two or more clinical teams to exchange patients and provide seamless care is a meaningful definition of interoperability. So we'll see. We'll see how that goes. All right, back to FHIR. No, I don't want to talk about FHIR, but I do want to tell you about API. So FHIR is fundamentally an API, application programming interface, an agreed set of requests and responses between two software programs. So they agree on what they're going to ask each other, how they respond, how they're going to actually talk to each other, how they're going to secure the interaction, and what the business obligations around that are. And then the service API has real-world consequences. If you make an order through the Amazon Service API, sooner or later, somebody will appear at your door and hand you something for real. So the APIs have real-world consequences around the business obligations. Our mission is to define one of those for health. Sorry about the coughing. I'm pretty sure I had COVID last week. So we describe health records, the whole healthcare ecosystem, not just an individual's health record, the records of the entire thing as a set of locations on a web server. And so our business is to say what records exist, how are they represented, what do they contain, how do you find them, what operations can you do with them, and what obligations do people have when they talk to each other about healthcare. If you want to do a prescription, how do you represent a prescription? How do you actually trigger the prescription to happen? Which is different than merely making a statement that there could be a prescription that looks like this somewhere. Our business is to capture that and write it down as a standard so that everybody can agree this is how it works. The interesting thing about what we do is that we're writing a specification for every server. And of course, healthcare is inherently variable across different use cases, different jurisdictions, different domains, different business situations. And the other thing is we have no authority to change healthcare practice. In other business situations, they get together and they say, this is how we're going to do it. And somebody at the table says, well, that's not how we do it. Like the Swift banking background, for instance. And the Swift people say, well, you're going to do it this way now, but that's the bit that we can't say at HL7. We can't say to a government that says, oh, healthcare doesn't work like that in our country. We can't say, well, change it. We can't do that. And so what we have to do is work in a sort of a scaled model where we have the things that everybody everywhere agrees on, and things that individual countries agree on, individual domains agree on. In some fantasy world, I have this fantasy that We'll get everybody in the world who does this stuff, and we'll gather them into the MCG, and we'll surround them with the army and say, you can come out when you all agree. Like that'll ever happen. We'd die rather than agree. I am going to go for 10 seconds and get me some water. I'll be back.
Thanks, everyone. While Graham's just ducking off to grab some water quickly, and thanks for the reminder that there is COVID on the surge again, Grahame. I really hope it wasn't COVID last week. Have a think about some questions that you'd like to ask at the end of this discussion, and feel free to pop them in the chat. Just while we can give Grahame a quick break.
All right. Yes, I think it was COVID, but I tested negative, but man, it looked like it. Okay. All right. So web API. Yeah, technical stuff. We use common content model across the entire spectrum of activities. An open license, and it's really an open community. That's really key. You can use FHIR for whatever you want. There's no license restrictions. Creative Commons, public domain, whatever you want. We're very pragmatic. We provide lots of tooling and testing infrastructure. Those are things that make FHIR good. That's fine. But so what? I don't like to talk about that. I thought I took those slides out. Enough about that. I don't want to talk about this. There's this really difficult relationship between standards and innovation. Really tricky, because the whole point of a standard is to stop people from innovating in the space where the standard exists. But by so doing, you make it easier to innovate in a different space. It's a really key point about what standards do. They move innovation somewhere else. Does it work? Sometimes it works amazingly, and sometimes totally fails. And as far as I can tell, the success chances for a standard are about the same success chances as for a startup. 90% fail. They get published, everyone looks at them and goes, nah, don't do that. And even if the government, tries to force people to, they don't. And so it seems to me that standards in innovation are like one of these dogs. They can go in different directions for a little while, but sooner or later they're going to snap back together. And the longer you let it go, the more painful that'll be. But it's really hard. There's no in principle way to define that relationship. It has to be found experimentally. Writing a standard will change the ecosystem. And while the ecosystem is changing in response to a standard, innovation is happening both within the standard and on top of the standard. And so really, this is just an ongoing challenge we have to deal with. So let's talk about healthcare. The key point for FHIR at this time is opening up electronic health records. Typically, that means hospital systems, and that's where we're leading with on the nose. But for me, it means all healthcare record systems, whether you're a registry or a primary practitioner or a tertiary practitioner or a specialty or an allied health or whatever. We want to provide an API that allows access to the data and the services that these record systems represent. We want to do that with our integrated security so that it's basically part of the system. We now have a working system in the States based on the Argonaut project, which is making available data from the EHRs to any software that's authorized. We're now in the production phase of that process. We've prototyped, we've specified, we've delivered. Systems are in production. We still need more data available. And the main focus in the US is to get more data so we can do solve more healthcare problems. But once you can run your software inside the EHR with integrated security, all sorts of really interesting healthcare processes become possible that couldn't be imagined beforehand. And we're starting to see those being imagined in the United States. There's no push for that here in Australia at this time. I wish there was. You can go a step beyond that and start saying, and this is what has happened in other industries, that you replace the existing ERP-based EHR systems, big systems, huge install costs, where you spend a lot of money training people how to use the EHR and training the EHR how to be yours, how to fit with your rules, and you replace them with existing commodity services provided out of the cloud, clinical record as a service. And we're almost at that point where the standards support that. And there are now in the States, the EHRs you can buy out of the cloud, just bang, and they can't customize them. You just have to customize yourself to them. And then the institutions pay per patient record. And the thing about this is, now that we're nearly at this point, you're talking about a 1,000th of the cost of the existing systems, like substantial reductions in cost. But the organization has to give up all of its specialness. It has to let go of its belief in itself and just say, we're just another hospital. And that's a huge cultural shift to make. So we're starting to see this. It's like these cloud providers going into the small institutions, like where you can count the number of beds on a single hand or two hands, and then they'll just gradually scale up. That's how it works. We've seen that in other industries. For me, that's the goal, is to get to the point where all these clinical record systems are totally interoperable because they're built from the ground up on FHIR and other related standards. But it's a 20-year process. It's not a quick thing, never going to be. But for me, the whole point of all this is to empower patients. There's a huge focus at the moment in making data accessible to patients so you can get your health record, that you can get data from the patient to the system, although what to do with it, big challenge. It's different, big challenge. Allowing a patient to control data sharing, which I think is something that's pressing in the short term, as the rules around data sharing get more prominence and more focus. There's more and more technical debt around bad data sharing and data leakage. And really, we should get it to the point where the patients got the data, not the institutions, because institutions keep data for institutional purposes, not to serve the individuals, both the providers and the patients. There's even work in the States on creating a single common patient record where the patient has the record and the record goes to the hospital with the patient in concept. And then everybody works on that record. And when the patient leaves, they effectively leave with the record. Of course, it's not like a single thing. You keep access to it. Anyway, that's what they're working on. But from my point of view, for most patients, there's a few special cases like mothers of little sick children or people with unclear diagnosis who desperately want their records. But the rest of us is like, yeah, we know we're sick. The data doesn't help us, doesn't change our lives. It's services that do. And that's where the focus will eventually go. But we can't have services that are patient-focused, patient-centric, until the patients have their records. Now, everywhere I go in the world, and for my family here in Melbourne, the huge challenge we have is coordinated care, the gaps in the system. We have scheduling communication problems, we have conflicting care plans, conflicting payment methods, conflicting definitions of what even success is, and you end up resolving this as a patient. Take my mother-in-law. No problem. The GP referred to a surgeon. The surgeon put her on a medication. She went back to the GP and the GP said, oh, you shouldn't be taking that medication. When she went back to the surgeon again, he said, if you're not going to take my medication, why am I talking to you? But how is a patient supposed to resolve that? It's crazy. But that's common. In fact, it's normal. I've been there. My kids have been there. My parents and my parents-in-law have been there. That's nuts. FHIR enables services for distributed care plans. It's particularly bad, this problem, coordinated care for mental health patients. Shocking for them. I was talking to Ian Hickey about this a couple of weeks ago. It's a disaster. And I've experienced that in my personal life with family members. FHIR enables services for a common care plan that everybody has access to, that everybody can communicate with each other directly over, and for virtual clinical review. I really believe that those are the health goal that will be transformative. Yes, there's many, many challenges. As I said, IT, we can do this now, but to actually do it requires, we have the standards to do it now. We do not have the software to do it now. We don't have the culture or business practices or funding mechanisms to do it now. Those are our true problems. We are working towards the standards that allow us to rebuild the healthcare system to be patient and process outcome focused rather than institutionally focused. And I want to repeat something I just said. Institutions keep clinical records for institutional purposes, not for the benefit of their employees, the care providers, and not for the benefit of the care receivers or their families. And that, for me, that's a key thing that needs to change. We can rebuild the healthcare system towards consistent clinical practice, best practice with considerable IT support. And we can now envisage a automatically learning system where we know what the evidence that we're practicing on is, what our practices are meant to be, what our practices are, what the outcomes of those are, and what the full circle feedback mechanism is. We can envisage all those things, and FHIR enables them, but it's an enabler. It's not a solution. We need new community infrastructure at many levels to build on top of what makes IT is theoretically possible to turn it into what is actually happening. And so for me, the key to that is to build many communities that are able to capture and share and grow that community treasure I talked about. And in order to do that, they need solid governance. You know, what I say is that the financial size of the ecosystem that FHIR builds is $1 trillion. It's not that FHIR is going to get $1 trillion, but people will spend $1 trillion on healthcare services provision that they would need to spend again if they changed from FHIR. $1 trillion is a very large amount of money. Our governance is critical to build confidence and trust. And any of these community building organizations, that's key. And I'm telling you, if you look around the world, you should see this is being eroded. A lot of what's going on in the world today is to erode trust in governance in order to destroy what we have. And so for me, it's most critical that all of us spend some of our time contributing to civil infrastructure to push back against what's going on in the world at this time. You can do that by contributing to FHIR or any of the other allied communities or professional societies, but please do that. As for FHIR, we set out to disrupt healthcare and healthcare IT by significantly reducing the cost of data exchange, making it easy and natural to use the web for healthcare, the web infrastructure, the web culture, the web for healthcare, encouraging the development of an open community that we can have a solid base to scale computation about healthcare. But again, these are just enablers. It's actually healthcare processes that matter. Anyway, thank you for listening. I'm happy to take questions. Thanks.